So for someone who didn't hear my first lecture, I'm a senior pain physician in Hadassah Hospital in Jerusalem, which you can see in the background. I lead this treatment of musculoskeletal pain in the pain unit. You can see the hospital down there in the right-hand corner. I just wanted to clarify something from the previous lecture. I'm not sure if it was obvious, but when I treat rotator cuff tendons, I don't only treat the rotator interval, obviously. I obviously sort of treat the tendon attachment, and if I can get into the tear under ultrasound, I do that also. And I try and treat at least 2 of the 3 of the tendons that I spoke about. So anyway, so now I want to speak about the, I call it the Lumbo-Sacroiliac complex because it's really one complex, and it's not just that. I mean, the lumbar spine and the sacrum and the ilium and the sacroiliac ligaments and the sacroiliac joint and the hip joints and the gluteal muscles and everything really function together. And if one's dysfunctional, it's going to affect the rest. If you have a fusion of the lumbar spine, especially L5S1, it's going to put a ton of stress on the sacroiliac ligaments and the joints with movements. It's not going to shock absorb as well, or the lumbar spine. It's going to put a lot more stresses on. If the gluteal muscles are dysfunctional, the gluteal muscles are extremely intimately connected to the whole of this complex here. So basically, one second. Basically, as with the rotator cuff and as with everything else, we treat the whole thing together. So when we talk about regenerative medicine, we talk about, I mean, we use the concept that our body is actually loaded with pharmacology to heal itself. And these regenerative patterns that we're trying to use, we just need a push. We need to push them in the right direction. So, one second, why isn't this working? Dubi? Yeah. Can you come here? Oh, here it is. Okay, my keyboard's not working so well for some reason. Okay, so there are various sorts of regenerative injection therapies. There's a simple dextrose prototherapy, which I talked about. We use various concentrations of 12 to 25% dextrose, and these cause the body to release a lot of type 2 monocytes, which send all sorts of cytokines out, good cytokines, and recruit a lot of fibroblasts, and which in turn builds and thicken collagen tissue. And this is been proven in basic science studies. There's the platelet-rich plasma, which basically theoretically has the growth factors in lots of all these little vesicles loaded with growth factors, and there are lots of different growth factors there. There are the various sorts of stem cell injection. We can use bone marrow concentrate or bone marrow aspirate, or you can use adipose tissue, which has a lot of mesenchymal stem cells, which is a whole lecture in itself. And so basically, we often have our patients who are suffering from a ton of pain, and they're suffering, you know, they say, doctor, take my leg off, take my arm off, I can't deal with the pain, blah, 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 et cetera, et cetera. And obviously they're saying it jokingly, take my head off with all the headaches they get, don't want it. But we want to actually transform these patients into a functional unit that functions together as a whole, and not just the skeleton, obviously, but with the muscles and nerves and tendons and vessels and everything together. So I really believe that within a decade or so, apart from treating really inflammatory joint diseases and various sort of nerve problems, corticosteroids are going to be here. And I think we are moving into an age of regenerative injection therapy. So basically, as I said with the rotator cuff, a successful treatment depends on a methodical, comprehensive evaluation and treatment. And as I said with the rotator cuff, a stress doesn't fall on one ligament or one joint, it falls on a whole area. And we want to strengthen that whole area with as much as we can when we deal when we do regenerative injection therapy. So we want to treat a functional unit. We think rehabilitatively, including exercises and posture and ergonomics, and not just a one-shot treatment and abracadabra. So that's what I said before. So we're not like horses and dogs and even monkeys that walk on 4 legs and run on 2 legs. We are bipedal, and so when we walk, when we run, we sort of land, we put all our weight on 1 leg, and that puts a lot of strain on our lower limb, and the sacroiliac ligaments are bearing the brunt of that, a lot of that, and are shock absorbing, and that's one of their main functions. So there's a few reasons why the sacroiliac ligaments are just so vulnerable to dysfunction. The first thing is, and it's quite amazing, is that the sacroiliac joint is the only muscle, or the only joint that a muscle does not cross it completely, which means that its stability is relying on the ligaments. But that's only partly true, because while no muscle really crosses it, we have fascia coming from all different areas, from the abdominal fascia and the latissimus dorsi and the thoracolumbar fascia and the gluteal muscles, and everything sort of all crossing, crisscrossing, and everything's adding some sort of stability. So that if we require all these muscles, even the abdominal muscles, to be coordinated with our back muscles and our gluteal muscles if we want perfect function, which doesn't always happen. So there's a concept called tensegrity. I'm not sure how many of you heard of it, but this was coined by the famous architect Buckminster Fuller, who coined this term tensegrity, which is basically, which is combination of 2 terms called tension and integrity. And what it's actually referring to is that every structure, whether animate or inanimate, is supported by these two concepts. So the pelvis is a classical concept of this tensegrity model. If you take like a basket like this in the bottom picture here, it's like or any Hessian sort of bag. If you can imagine, or this figure up here, it's a sort of analogous sort of structure. If you're going to pull on one structure there, it's going to distort this whole thing. It's going to create a lot of tension on some of the ligaments, the analogous ligaments, which are these, and it's going to compress others. And that's going to be dysfunctional. And this is so much like, if you can think of our pelvis as analogous to sort of a bag like this, where you've got some ligaments that are stretched and some ligaments that are tight, or some parts that are fused, or even an osteoarthritic joint that's just not mobile, that's going to cause a lot of extra stress to fall on the ligaments. All these can lead to some sort of dysfunction. So the functions of the SI joint, it links the lower limb, the lower extremity with the trunk, and it transmits load both ways. It shock absorbs from the ground. It provides stability in contrast to the shoulder, where we want lots of movement, but at the expense of stability. The sacroiliac joint and the hip joints have to provide some sort of stability, and therefore a reduced range of motion, especially like with the hip compared to the shoulder. So the sacroiliac joint only moves 2 to 4 millimeters, but that is critical for shock absorbing. So here are the sacroiliac ligaments that I'm going to talk about, or the whole lumbo-sacroiliac ligaments that are critical. This is the iliolumbar ligament, connects the transverse process of L5 to the iliac crest, and there's also part of it coming from the L4, which is very critical in transmitting load from the lumbar spine down. This is the sacroiliac interosseous ligaments, which sort of span all along here, and there's different layers to this. Here is the sacrotuberous ligament. It comes down sort of underneath and blends with this, and sort of fibers come from across here and blend all together, and they all come down and all insert into the ischial tuberosity. And this is the longest ligament in the body. The sacroiliac interosseous ligaments are the strongest in the body. And these points here that I've mentioned are points that I usually inject. I often also inject the facet capsules, especially the idea if you've got some sort of lateral listhesis or a spondylolisthesis, and sometimes you don't really see it on X-ray or on CT imaging on lumbar spine, because people are lying sort of supine in a sort of a tube. It's not taken when people are walking around and jumping around, but if you have a little bit of listhesis, like the lateral or anteroposterior, then that's going to, when they're standing or running or functioning or upright, then that's going to put extra stress on the nerve roots, which is it's going to put more traction, which means that people may have a minimal amount of spinal stenosis, but when they're walking and upright and running, then that'll be much more symptomatic. So the idea of injecting the facet joint capsules, and also you can inject the interspinous ligaments here, is to try and stabilize that area. And people do function better. I mean, people do report they have much less pain, and they're functioning better, they're more stable. So the symptoms of sacroiliac dysfunction, 94% report pain in the buttocks, 70% in the lower back, 14 to 26% referred down to the groin, 50% referred down to the lower limb. And this is important to take into account. 28% of patients with sacroiliac dysfunction refer pain down to the leg below the knee, and 14% even up to the foot. So pain referring down to the leg past the knee does not equal spinal radicular pain. That's a concept that we have to break. And very often when we treat these ligaments, then their referred pain is much improved. Sacroiliac dysfunction can cause paresthesias, usually not in a dermatonal distribution. Sometimes patients complain that their leg sort of gives way as they walk. It's a sudden sensation of instability. The pain is made worse by sitting for long periods, and people often have to change position frequently. It may be exacerbated by standing. And not to forget to inquire for my female patients in reproductive age if pain is worse during or prior to menstruation or during pregnancy. So pain referral from the ligaments, okay? I said that now these studies have shown, I'm not going to quote all of them for lack of time, but the referral patterns produced depends on where you stimulate from and how you stimulate. If you still with a needle, or you still stimulate with hypertonic saline. This is a referral pattern from the iliolumbar ligament. Refers to the groin, inner thigh, a little bit laterally sometimes also. It attaches to the quadratus lumborum, inserts into the iliolumbar ligament. So sometimes you get pain referral from quadratus lumborum together with iliolumbar ligament dysfunction. This is a referral pattern from the sacrotuberous ligament that can refer, doesn't always, but can refer all the way down the back of the leg up to the heel. And also it's been found with the sacrospinous ligament. It's not consistent, not everybody refers all the way, but pain that refers down the back of the leg can be from the sacrotuberous or sacrospinous. So sacroiliac physical examination tests. So there's 6 tests that we can use. The Faber, which stands for flexion, abduction, external rotation. We add an E on the end of it because once you've done the Faber, if you apply sort of an extension momentum onto that, then so we add an E onto that. The thigh thrust, which I'm doing on this patient here. Distraction, compression, Gainson test, and the sacral thrust test. Now, none of these tests are actually absolutely specific for sacroiliac dysfunction. So we usually try to combine as many tests as possible. And the more tests that are positive, the more likely the patient is going to have sacroiliac ligament or arthritic joint symptoms. Some people, I've seen in a study that someone described the resisted hip abduction sacroiliac test, but that tests the gluteus medius, which actually, as I said, is very intimately connected with the sacroiliac function. So I don't think that's a sacroiliac test, but it should be tested alongside with everything else. Now, the thing is, though, one could say, okay, well, maybe the test is to take the patient to be injected under fluoroscopy, inject the sacroiliac joints with local anesthetic, and see whether the pain goes away. But that has a few limitations. First of all, the sacroiliac joint has a total volume of 2 cc's. So if you're going to inject contrast and then local anesthetic, and if all that exceeds the 2 cc's, you will probably have injectate coming out of the different foramina or different areas, and that will leak out into the ligaments, and it won't be specific for a joint problem. So you can have, if it's negative, and the other thing is, if it's negative, it doesn't mean that the patient has no sacroiliac pathology. He may have pain, he or she may have pain coming from the sacroiliac ligaments, not from the joint. So the injection into the joint under fluoroscopy will diagnose if someone has sacroiliac arthritic pain and not ligaments. So I think it's important, if we're going to combine, we should combine both of them. And as I said before, the more when you have the test, the more you combine them, the more specific it will be for sacroiliac pathology. So here is a coronal section of the whole sacroiliac sort of complex. You can see that here's the sacroiliac joint. The superior entrance is much wider than the inferior entrance. Okay, and when I inject, first of all, a number of areas. If I want to inject the joint, if you want to inject only the joint, studies have shown that the injectate, it's much more reliable to inject the lower entry through the lower entry around here, and the injectate has been proven to spread much more effectively. I often inject the upper entrance as well, because at the same time, with the same prick, I will inject the ligament and inject the attachments to the sacrum around here and to the ilium, as well as into the joint. So with one prick, I'm injecting 3 areas. In addition, I will inject the attachment here to the the transverse process, the iliolumbar ligament, the sacroiliac interosseous ligament. So I'll start here and attach and target this area. And I want to I can inject the sacrotuberous attachments here, and like I said, the fibers sort of fan out, coming out all over here together down to the ischial tuberosity, which you can't see here because it's a different section. And I won't inject all that in one session. Okay, so I'm not that cruel and not that aggressive, but I'll do it over a number of sessions, and patients really do improve. And also, I said, as I inject the facet joint capsules. So here, clinically, if I'm going to palpate, the iliac crests come to the L4 level. When you take the thumbs together, they're slightly lower than the palm of the hand, so that comes to L4-5, which is at this level. The iliolumbar ligament is sort of a little bit lower than the L4-5 level, about 3 centimeters laterally. And if you want to do this blind, you can just go straight down. I prefer to do it under ultrasound. The sacroiliac interosseous ligament between the midline and the sacroiliac and the PSIS, which is at S2 level, and the just under there, I target the sacrotuberous ligaments and the ischial tuberosity. And at some point, I also inject the greater trochanter because, as I said, the gluteal muscles are very intimately related. And I'll do that over a couple of sessions. So if you want to see this under ultrasound, Okay, so this is a transverse view of the lumbar spine. You can see here is the spinous process, and here is the here is the facet joint. Oh, sorry. Here is, I can't move this mouse properly. Here is the facet joint here and here. You can see that nicely. If you're going to inject from the side, longitudinal, have a probe longitudinally along all the transverse process, along the facet joints, then here is caudal and here is cephalic. You can see the facet joints here, coming here. So you can inject one of those, put your needle in, and then you can rotate the probe 90 degrees, whichever way you started, and do the next one, and you can see that your needle is in place, and then you can inject. Okay, so here is the sacroiliac ligaments, and the sacroiliac joint and the ligaments. So here is medial, and here is sort of lateral. This is the PSI, posterior suprailiac spine. Here is the sacral foramina here, the S2 sacral foramina. So I would put my needle coming in from the medial side here, straight in and go into the joint. This is into the superior entrance of it. It's not really right up the top. It's sort of a third of the way down into the joint here. And there's a, coming from the other side, needle coming into the joint. So if I'm putting a needle in, I will, in one prick, I will direct first into the joint, and then I'll come out and I'll go into the posterior suprailiac spine and inject those. You can see those ligaments here. And then I'll come out and then target the sacrum along here without getting into the sacral foramina, of course. And that's injecting the ligaments as well. If I want to do the lower entrance, which is a lot more challenging, here is the median sacral crest. So this is medial. Here is the S3 foramen here. And the lower entrance to the joint is sort of pretty much, there's no sort of, not, it's sort of pretty much level flat, and it's a much smaller entrance. So that's the lower entry to the joint. So the take-home messages are here. Well, first of all, and as I said in the earlier lecture, so if you're using a regenerative injection therapy, you can use dextrose prototherapy, you can use PRP, you can use platelet-rich fibrinogen, which I sometimes use, which is a whole different method. You can use all sorts of bone marrow concentrate and bone marrow aspirate. Those are really the most common ones used. As with the rotator cuff, all my public patients are treated with prototherapy because platelet-rich plasma is not part of the health basket. And my private patients, I usually do PRP, and usually those who haven't improved with the prototherapy. So the take-home messages are that the lumbar, sacral and iliac areas, and the gluteal muscles and the hips all function together. And one must address either with prototherapy or regenerative platelet injection therapy or other methods which should address that whole region, and usually over a few sessions if you want to get long-lasting results. Patients will have post-procedural pain for about 3 to 6 days at the maximum usually. There are some people who don't have any pain, and usually the older people don't usually have that much pain afterwards. Steroids will neutralize any anabolic effect that we want to promote, so that if anyone's had steroid injections within the last 2 to 3 weeks, I will wait until that time has passed, at least until a month, until I start prototherapy. And we want to avoid non-steroidal anti-inflammatory agents, because it's said that we may incite some sort of slight inflammatory response to get that collagen production moving, although dextrose has not been found to produce an inflammatory response per se. But in any of the case, we usually recommend not to use non-steroidals. So we want to also strengthen the gluteal muscles. And I've got an example of the gluteal muscle, an example of the exercise here on the right-hand side. And this is a sort of a fun exercise. You can do it with your spouse or with your children. But basically, to start off with, you stand on one leg, as in the picture. The standing knee is slightly bent. In other words, it's not locked into extension. With the contralateral, and it's sort of like you test a Trendelenburg test. So the contralateral leg is flexed to 90 degrees. So you're actually challenging the standing leg a little bit more than when you're lifting the leg a little bit. And then you can stand that, and you can move your flexed hip in different directions, abducting and lateral rotating and all sorts of things, and extending, and see if you don't lose balance. And to challenge yourself even more, you can take, let's say, a ball and throw it to your partner and catch it without losing balance, which is quite fun. So when you're doing this, you're strengthening all of the 4 main muscles in the hip. You're strengthening the gluteus maximus, medius, minimus, and the tensor fasciae lata of the standing supporting hip. So you don't have to go to Pilates and strengthen each one of them separately. You can do this by throwing your ball to a spouse that's standing on one leg and have some fun at the same time. So thank you for listening. If you have any questions, you can write me by email. It's do.wende at gmail.com. This is my website. If you have any questions, I'm pleased to answer. Thank you very much. And thank you for inviting me.
Thank you, Dr. Osnat, for your lecture. Do we have any questions for her? If we have any questions, kindly ask the question at this moment.
Dr. Wende, I have a question.
Yeah, okay.
As a spine surgeon, I often encounter the differential diagnosis between piriformis syndrome and lump and sciatic pain. So some doctors, they question the reality of the piriformis syndrome. They think the piriformis syndrome does not exist because MR or CT does not find any disc herniations in the lower back. Does not mean there is no disc herniation. So some surgeons, they advocated during operation they found disc herniation and the MR that did not find it. So piriformis syndrome, what's your opinion as a pain physician? Does it exist, or it can be only tested by physical examination, and medical images is hard to help the diagnosis of piriformis syndrome? What's your opinion, Dr. Wende?
Okay, so a few things. First of all, you have to differentiate between the typical, the classical piriformis syndrome that's described in the textbook, where you have radicular pain all the way down the neck, and where you have entrapment of the sciatic nerve. You have to differentiate between that and trigger points within the piriformis muscle. Like any muscle, you can have referral pain from trigger points. The trigger point piriformis, the trigger points in the piriformis muscle don't refer pain all the way down the leg. They just refer pain down the buttock and a little bit past the posterior thigh. So, and that's very common. And like the other muscles, the gluteal muscles, the piriformis functions intimately with the obturator internus muscle and the sacroiliac ligaments. And we often get a mixture of it all. And And often I will sort of treat the piriformis muscle or the obturator internus muscle, or both of them, with something like even dry needling or injecting local anesthetic into those trigger points. In terms of pure, real entrapment of the piriformis, as you say, like the I see it very, very rarely. It's classically described in patients who, not necessarily those with the anatomic anomalies, which are extremely rare, but in someone who has fallen and deep fall. And then I tell you the truth, I'm not sure what I'm treating. It could be that a lot of them are suffering from sacroiliac dysfunction, because people who have fallen from a major fall and maybe bruised their piriformis are often probably likely to sprain their sacroiliac ligaments. So I'm not sure exactly what I'm treating, but I just treat everything. I mean, like, you know,
Okay.
and patients improve. It's not a very scientific way, but that's a method of approaching. But that's what I do.
Okay, thanks for your answers. You know, as a pen physician, you are so powerful. You can dealing with all kinds of sacroiliac, you know, zone pain. Thank you so much. I'm glad to hear your presentation.
Thank you.